Yes, you can.
30 days.
Good evening, doctors. Welcome you all for the third edition of Cardio Next program. We are expecting course faculty to join in the next few minutes. So as you would be aware that this is the third edition, and the last two editions of the modules, which was taken up by Dr. Srinivas Kumar, our course faculty, is the programs. Because you are all aware that we have already created a WhatsApp group for Cardio Next programs. So all the doctors were already part of it. We have shared them the link where they can view a YouTube link where they can view the program. So we are expecting Dr. Srinivas Kumar, our faculty, to join anytime, sir. Once again, we thank you all for being part of this lecture. And as a 12-month module, and this month is and every month, fourth Saturday would be the program time from 6 to 7:30, max or 8 o'clock. And this is a 12 module program for the next 1 year. And end of the program, we will be giving the certificate also. So further deliberation would be taken up by Dr. Srinivas Kumar, our course faculty. Thank you all of you.
No.
Dr. Vignesh and Dr. Srinivas Kumar here. Vignesh, are you able to hear me?
Yes, sir. Yes, sir. 1 minute,
Yeah,
sir.
no problem. Take your time.
Yes.
Sir, good evening, sir.
Good evening.
Yeah, sir, we have crossed 100 participants, sir. We'd welcome you all, welcome you, doctor, again for the third module of our cardionics program, sir. It's a wonderful gesture from your side to accept our invitation to be the course faculty. Already 2 modules have aroused a lot of interest among the doctors who have attended the program. We have now what we have done, we have expanded it pan India. We have doctors registered to Kashmir, Srinagar. There are doctors who have been part of this program, sir. It is all thanks to you for your innovative way of conducting this web module, making it interesting, especially with Kahoot as a gaming thing where the quiz program is getting conducted by you, which is bringing in. And also we have communicated last time by you, sir. We have been every time you have an announcing quiz winner also. Last time CSI update books we have already dispatched to them. I think this time also you have got some plans. That is what we are aware of it, sir. We would request you to now take up the proceedings. And once again, I thank all the doctors who have logged in for this program on a Saturday to take it up further. Thank you, sir.
Can I stop this and share the screen?
Yes, sir.
Are you able to see the screen?
Yes, sir. Very much.
Shall I proceed or wait?
Yes, sir. Yes, sir.
Okay. Then good evening, one and all, and welcome to this third module of cardionics program. I thank Vignesh and all the people of Micro for making this possible and taking it a lot of interest in getting this to all the colleagues across the country. I thank all the doctors who are eagerly participating and probably interested to learn more about this. This gives us a lot of enthusiasm also to do such things more actively. The module, as discussed before, is deals with stents, various types. The most important, as you know, which has revolutionized interventional cardiology, is the availability of the stents. We became more courageous and probably are able to tackle much difficult lesions also because of availability of stents, and the quality of stents have improved so much so that even they're better trackable, and you're able to tackle a lot of calcific disease. Cardiologists that we initially, when it was done, it used to be surgical standby. Now it is actually standby, I would say. So basically, it is we don't keep the surgeons standby, but if it sucks at something, we're always confident that we can always put one more stent, and that's how stents are revolutionized interventional cardiology, I say. But with the availability of so many number of stents, and some of you could have experience with each of the types of stents, somebody could be getting confused which type of stents to be used and what is the data available. So I thought we will discuss some of those aspects which are patient specific and which are also lesion specific. Other type of data also which has come up in the past decade or so. With this introduction, I will proceed further, and I request all of you to make it interactive and type your questions in chat, and so that we can have a discussion. We can break after 20 minutes or so. Again, play quiz and then have some chat questions. Again, go to the next part of the lecture. As you all know, CFBG was there very well before. It started in the 70s, and that was the primary treatment for coronary artery disease. And in 80s, then the great man, 77 actually, Andreas Grundzig introduced angioplasty, but we had problems. I'll take you through and how this stent era began in 90s and DES era began in 2000s. And then that's how I think now we are into second, third, and fourth revolution of stent technology. We're all indebted to this great man, Andreas Grundzig, who initially, I don't know whether any of you are aware of how the evolution of angioplasty started. Do you know the story? Anybody can answer it in chat. Or how did it start first? This figure actually gives you an idea before. How to see the chat, Vignesh? Anyway, I think.
Sir, they can unmute and they can talk, sir.
Okay. Anybody wants to know what is this picture which is shown? Intra of coronary angioplasty I have put. Anybody can answer what is the background of this? Anybody can unmute and talk, I believe.
Sir, we have actually muted them, sir. If we'll have to then unmute all.
Okay, no problem. So what this shows is when Andreas Grundzig felt that balloon inflation would work for removing the stenosis, his boss and various other people thought he's a mad guy. And once balloons are inflated in the coronary arteries would rupture and patient would die. So, but he was very confident that it would work. So what he requested, you are about to do bypass. So before that, I will put this balloon directly and inflate the balloon and see what is happening to coronary arteries. Then surprisingly, nothing happened to coronary arteries. In fact, the lesions were cracked. Then later on, I think very comfortable, and he thought his idea would work. So that was helping. So this is he's very smart, Andreas Grundzig, and probably he's the person. 1977. He's the one on which the first angioplasty was done. This is a patient, and this is a doctor. So this patient was admitted for a bypass surgery in a sharing room, and when the other patient was post-op for day 3, he was having a lot of pain and he was not comfortable at all and crying. So this patient was waiting the side bed. Then he was thinking, tomorrow my fate will be like that. At that point, technique where without cutting, I would remove your block, but I have not done this before in humans, but I'm very confident that it will work. Then patient had a lot of confidence in Grundzig and said, I'm ready. But his boss didn't allow. But the patient insisted that I'll get non-invasive treatment by Grundzig. And that's how he did it. And plasty was performed in 1977, to be more specific, on September 16, 1977. He worked like this on his dining table, a lot of balloons and catheters. The first balloon is initially was made by Schneider. And then once the angioplasty was done, the plain balloon, the lesion opened up like this. And it was again rechecked later in 2000, and it is still working all right. So that's how the history was created. And then later on, again, he checked, then this conducted a lot of these courses. In 1995, one of the first angioplasties, but POBA, which we done in SGPGI. But the thing was, when the balloons were done, then the vessels were getting closed. So a lot of times, we were forced to sit with the patients as residents also. If something happens, we have to immediately address what to do. We were thinking to avoid this acute closure. That's how the stents have come. So to prevent acute closure, first it was studied, but later on, again, it was also shown to decrease the restenosis. How it evolved, I will just to take you through. Started with Palmer-Schatz stent. This is the first human implantation of Palmer-Schatz was done on December 31st, 1987. So exactly a decade, probably. 77 was angioplasty, 87 is stent. Giulio Palmer is the one who was instrumental in developing this. But areas gained were very high compared to balloon angioplasty. And then stress restenosis, again, Martellion was the investigator for this, and they showed that probably by using this, not only the immediate results, the patient did well, and the revasculations, repeat revasculations in the stent group was much less. That's how they became wiser that stents also decreased the repeat revasculations and decreased the incidence of restenosis, which is about 30-40 bare metal stents. So initially we used to do with resistant patients of maximal medical therapy, single vessel disease, proximal stenosis, because these lesions were very tough. This is to just recapitulate one of the first in the carrier. This is left circumflex artery. This was a patient who works in one of the film theaters. We still remember, he's still doing all right. Then we did the dilatations, and after that we put a stent. That's the marker similar to the stent. I think then the total where it was. But again, with the bare metal stents, we still had restenosis rates up to 20 to 50%. Then this was atherosclerosis, which is happening. Initially, brachytherapies were tried, would decrease the restenosis. That also helped, and at that era, antiplatelet drugs also came. The acute thrombosis decreased, and the stents were started behaving better. So we also had better technologies to image the plaques of Cardiology. Johnson & Johnson's company came, which is sirolimus drug called Cypher stent. Cypher, in fact, they labeled it to say it as a zero. Cypher means zero restenosis. Type A lesions which are done. They claimed that there's no restenosis with Cypher. They thought they conquered the restenosis totally. December 1999, 97 was the first stent, 99 was the DES with Cifor. One company came with paclitaxel, other with Limus, and then both stents were going all right. This was Taxus and this was Cifor. Going all right. Then Renu Virmani and others, many of them mentioned these drug-eluting stents. They have a good things of decreasing stenosis. They were bad and ugly because they delayed healing. They caused happening, and also abnormal vas motion. So research went on how to avoid this. A lot of different drug-eluting stent platforms came, and some are stainless steel, some are cobalt chromium. Then the Indian companies also started doing it, and one of the first ones was K4. Then later they became slotted tube stents. I would take you through the stent anatomy in a short while. Then we thought which stents are good, whether Limus group or paclitaxel group. Then comparison studies were done and showed that probably sirolimus drugs, the paclitaxel stents became less and less popular, and Limus group is being studied more and more. So if you now see the better quality of stents, now you have all the types of multivessel disease being treated, and total occlusions, bypass grafts, you name anything, and they started, we are managing them, bifurcations, restenotic lesions, all that. So this is the first generation stents, which became very trackable. Some of them were noticed because of polymer. So then research went on, and we went on to more benign and more patient-friendly, more human-friendly polymers, which is fluorocarbonates, which is actually initially Endeavor platform and BioLink, and then Promus Element and more friendly. Actually, if you put a blood on it, albumin gets deposited on it, and the antiplatelet effect is also seen with those polymers. That's how I think gradually more and more interest on the things came. And 1 minute. So then Limus group of drugs were becoming popular, and everybody was trying to develop various derivatives of Limus group of drugs. Coming to the various things, people have started surprisingly getting into so many types. Drugs are available, you take select because of the experience of the doctor treating. Similarly, you need a lot of experience to decide on which type of stents is used in which lesion, which patient. In choices, strut thickness. If you see the predominantly what are the important things of a stent is basically stent has to be deliverable, and it has to give an immediate good result. And then longer follow, immediately it has to be safe to the patient of increasing TLRs and restenosis rates and follow. If you have to see how this is happening, the 4 important components of any stent would be basically stent scaffold, which could metal, which is a stainless steel or cobalt chromium material. Then because the drugs cannot be directly deposited, initially the polymers were used. Then later on, the polymer-free ones are also being tried by making porous surfaces on the stents. So that is a drug, and the coating to track the stent and all this. So these are the important components of DES. So advancements went on to happen to improve the research in all the 4 fronts. Then stents, so initially, which I said were just long wires mesh from one tube, it is being cut into the various designs. Then that's how they became having more radial strength. So then later the modifications also happened, wire configurations were also seen. And then this is various companies had different types of designs. So basically, if you peak, this is called as trough, and the attachment is from the peak to trough here. This is peak to valley, this is Zions platform, and then in between both is Orsero platform. Each of them have some advantages and disadvantages. Onyx, again, advantages of it will take you through. Metal to artery ratio, though you have the, suppose less of, to avoid the less of plaque prolapse, you want more approximate covering uplands. If it is too much, then again, probably restenosis could be high. Somewhere 13 to 15%, 18% ratios is what is acceptable now. At the same time, stent should be also, the scaffolding should be good. It has to be adhering to the arterial anatomy with the complexities and the tortuosities of the arteries. Then when they were making the struts thin, you should also have the radial strength to keep the stent opposed well to the walls. And you have the existing stent struts, which are mentioned here. And then geometry of the stents, connection of the stents matters in maintaining the strength of the longitudinal strength of the patient. If there is stent, and they could get collapsed. That's what was happening in the earlier version of Promus stents, which were later modified. So that's how the longitudinal shortening, if the struts are too thin without proper, and we could miss the lesion, or patients could have trouble and follow. So again, once you have deployed it, it should remain same in the same way it is deployed without further shortening later. Other struts in between these stent designs. What you call is many of the people would get confused between open cell and closed cell designs. So basically, if you have this entire thing open like this, it is called open, then probably it would be closed design. Many of the stents have now a combination of open and closed cell, because we know that closed cells are required to maintain the strength and open cells are required for the side wedge access. And depending upon the type, probably most of the latest versions of the stents have 1 mm around the axis, so that it would be easy to take the newer balloons through the stent struts if you have to open the dilate. These struts, which have maximum open cell design quality, is preferred. Then crimped and expanded images, again, what it is trying to show is once it is crimped versus expanded, the stent should not get shortened. And the markers, and this should be received that because of the improvement of technology. I'm dealing with most of the US FDA approved stents, not much discussing with the Indian type of stents, touching upon some of the newer version of the stents which came in India. Our discussion is around the US FDA approved stents. So stent material is another thing, balloon expandable stents. You have stainless steel, platinum, chromium, cobalt, chromium. All this is because it has to be having higher radial strength, radial opacity, thinner struts possibilities. As we now know that strut thickness is important. The more thinner the struts, the more better it is for the patient. The first generation stents, which had a very thick strut, Cypher had 140 microns thickness. The latest second generation, third generation ones are very thin. Now as low as 60 microns is Orsiro stent. I think it is mentioned here 61 microns is the lowest profile stents which are available. And that's how the stents become better trackable type of drug which you're using. So these are the polymer coating is what, again, as I mentioned, is important. So in the stent material over which you have a coating all around top coat design. And then depending upon the drug which is there and the polymer type, which most of the materials are now fluorinated polymers and which are very patient-friendly, human body-friendly. And the beauty of these polymers now, unlike the Cypher and Taxus, which had toxic polymers, is these are supposed to be thrombo-resistant. The aluminum gets deposited on those polymers, and it doesn't allow this. Actually, that's how I think some of the studies which came, the drug-coated, latest version of drug-coated stents fared better than the bare metal stents, surprisingly, on follow-up. Some of the reasons when they were trying to see, that was probably the stent. If you see the various commonly used stents which are available in the market, I mentioned here, most of the things are limus-based drugs. If you see, there's no paclitaxel. Zymes has everolimus. Resolute platform is Oterlimus. Synergy again has everolimus. Ultimaster is Synergy. And the drug elution patterns is also, if you see, it varies from 90 to 120 days, maximum of 180 days, because that is the period in which the maximum restenosis happens. So if the drug stays to, would be least. Then which phase of the cyclic replication of the drug is acting? If you see, most of the libus drugs act in the G0 phase. This is a cytostatic new cell formation within the stents is prevented. Now let us see briefly about some of this evidences of this stents available and the various indications. Zymes, I think by far is like the Cypher of first era we have compared to all others. They started with Spirit 1, 2, 3, 4. I really appreciate Abbott for getting these multi-center trials to our country. And many of our physicians and centers in our country were also made a part of it. And they did in India with about 1,000 plus patients in 2010. And Spirit Woman was another study in which, again, specifically it was studied for women patients. And then later they had also Excel study which came left main subset. And now we are going more towards a short adapt and single antiplatelet drug things. And then expert CT, all that was tested in the Zymes platform. So any new stent comes now, there's to keep testing with the Zymes stent. This is Spirit Woman study. We have the principal investigator. We were the leading recruiters in the 2007, and probably 67 patients were recruited. All patients did well. That's how it became the stent of choice in women in those days. Stent thrombosis rates were very less, and then that's how, as it goes on and on percent. And we have the longest follow-up data up to 10 years in this platform. And about 15 lakh plus implantations run in the country, overall the world. I think they have the leading market as of now. Then 15 million implants, that's what is probably Zymes. But you have to also know where to prefer other platforms like Resolute Onyx and Orsiro, and things like that, which you'll be dealing. If you see, to just precisely mention to you one or two case examples, if you see which is best profiled in low cranial view, I did show this before, and such sort of things where precise placement is required. The Zymes platform has an advantage that the marker and the stent start together. So the position, again, I need not go into details, but then probably that sort of things where you need accurate placement and limited only the left main, probably you could use. Similarly, it could be also LED osteal placement, L6 osteal placements without going on to impinging it. So you could take the advantage of this to use the right stent and do it immediately faster. Otherwise, sometimes there's left main inflations could lead to bradycardias and hypotension. Patient could develop trouble. Other important thing, once you're doing an osteal stenting, is what we also do a part and then probably inflate. We also image it. It is not a point of discussion today, which is dealt in the last class. But what is important is precise placing of the stent. If it is required, probably this platform scores over it, and it has a radial strength to keep it follow doing all right. So that's about the precise placement. See this. This is another 40-year-old male, chronic smoker, unstable angina. You are not able to see what is happening here. You have diffuse ectatic vessel, long segment disease, bifurcation, RC, and PLV distal disease. And same thing is seen here. Obviously, 40-year-old, we don't want to send the patient for surgery. So we decided to proceed, explain repeat TLRs could happen, and started doing the procedure. As you see, we wide both lesions, started dilating. Then initially, sometimes unless the proximal lesion is very critical, generally we tend to tackle the distal lesions. And then we have used distal stent here. Then we went on to go on to tackle the PDA lesions. For the sake of time, I can't go into all the details, but then sometimes you need to take the help of body wire to track the stent, and the entire artery was reconstructed. So this, you see this pre-image where you have ectasia, narrowing here, narrowing at the junction, narrowing distally, narrowing, and this had a very type 1 LED which was occluded a long time back with a patient and had no RWM, nothing. So this is huge RCA which was behaving like LED, was tracker stents which are available. Such sort of long lesions where there's a high chance of restenosis in younger patients, probably we bank up on this platform to have the better results. But you should so that's how we are able to be confidently deal with this sub all right and the follow-up. I think before going to other platform, I finished talking about Everlumus, this Science platform, and probably we could have some discussion Kahoot or we play basic Kahoot quiz. Any chat questions?
I think there is a chat question. Yes, sir.
Dr. Ravindra Reddy to everyone, sir, what is the status of bioabsorbable stent and evidence and new generation? I think if you give some time, Ravindra, and very happy that he joined, we will discuss that in the coming. I'll end with BVS and then we'll have more discussion on that. If you by BVS stent which will come to market, I will show you the data in the end of the talk. Give me a few minutes to change onto that and then probably we'll play this basic Kahoot quiz. And meanwhile, I want you to more people to put me the chat questions regarding whatever you spoke. Any chat questions, more questions, any doubts in regarding what? You're able to see the new screen of iPad?
Yes, sir. We are able to see that, sir.
I think for people who are seeing the screen, you can join this challenge if you type this number there, 0603 2428. Is something wrong? Are people joining?
Okay.
I don't see people.
Yeah, just checking, sir.
Some issue in this thing, or is it okay? Can take 2-3 minutes.
Yeah, 1 minute, sir. Yeah, they joined in, sir. We can wait for a few minutes, sir, so we can have more participants, sir.
Yes, we'll wait.
Yes, sir. So,
Anyway, I think some of them need help. It is coming. I don't know how to take it. Each time this is.
can you play it, sir?
Yeah, I'm just trying to do that. Actually, this is the earlier version played thing showing. I think they can join with this. That was a old one. Sorry, 0476 5335. That's why many could not join because it was an earlier version which had some limitation. 0476 5335. Bottom line you get 0476 335. When you open your Kahoot quiz, below it, you enter your PIN, it comes. Once you enter, then you'll be able to join. There's some problem, I think, this time. Only one person could join. Yeah, I think there are more joining. 4 are there.
Since we have changed it, now they will be logging in through this, sir.
Okay. I'll put the share PIN again.
No, it's fine, sir. We are taking it, sir.
04765335.
Yes, sir.
Anyway, I think they'll participate in the advanced one also. And some of them, the basic ones are, I made it just to.
Yes, sir. You can then start.
I have now 11 players who are logged in. And 12. The first stent type to be used in 1988. I put a figure to point it also. Zines, Pharma Shots, and Meris. Cypher, first regulating stent. Zines is the most advanced present stent, which is commonly some of them right and some of them may be taking more time. Then NK has answered right. If you answer it faster, also you get more points. Then probably as we go, the type of questions also will increase. What does cipher mean? 10, 0, or sun? So why was the term cipher given to cipher stent, indicating what? We know that cipher as revolutionized. I mentioned the answer here is basically cipher means 0. 0 restenosis. To highlight that aspect, they have kept it as a cipher stent. I think NK is leading now. Then we go on to next. Which most important drugs which decrease the MACE, antithrombotics, antiplatelets, silastazole, or statins? So obviously, when I mentioned here the above article of Antonio Colombo, where the lot of modifications, and then antiplatelet drugs is the ones which have decreased stent thrombosis rates, and then probably change the way we treat these patients. The figure is there above. I wanted everybody to know this, and if you can type the answer, that main person in the apron is also could score you additional marks. Open the talk with it. Many of you would know it, but just to encourage more people answering, I've kept it. I think Andrea is going to see his answer. The next besides him was the patient. The most commonly used drug in drug-eluting stent platforms now is what? Paclitaxel, heparin-based, Robucol. The basics would be touched with basics of stent with some interesting history points. That's how I kept it. I think Limus group of paclitaxel is given up. Robucol is another thing which is thought to be better. Combinations were tried, again not useful. Heparin-coated stents were also tried before. Initially, they were supposed to be better than the native bimetal stents, but later given up because again they didn't work. So everything is research is going on the Limus derivatives. So 5 questions, I think. Then this is going to practice. I didn't answer here. That's why on my thing it is showing. That's okay. So I think we finished this. The answer, the final thing would be again mentioned in the end of it. That is the end of a basic quiz. Now I'll stop sharing and also go on to which type of stents which we select depending upon what lesions, what patient anatomies, and some more details about other new platforms of stents available, which we'll discuss. Then at the same time, when the science platforms were going on, Resolute Medtronic was also doing active work, and the Resolute drug-eluting stents were going to be tested with science platforms, and both of them did perform well, even in the complex scenarios. Resolute multi-center trials were done in the US, Japan, good results on this platform. Resolute Asia, including the large stents of 38 mm dual vessel cohort, we are part of this. And then significant number of patients were recruited, and this stent also proved that it will be useful. Then research went on. They modified the stent, design of the stent to onyx, and stent sizes also decreased. Even from 2 mm, it was made available. And that's how this went on to treat small vessels also. Small vessels, they said 2 mm, 2.25 mm. Then the advantage, the beauty of this platform is supposed to like metal. Initially, they have platinum iridium core material inside. That's how they became more radio opaque. And then probably the same polymer was used, the Bilinx polymer, which was more user-friendly. Then, but the design was all this wire pattern were again united. Basically, not going to all the details, but it's basically fusion pattern of this wire material with the outer core and inside iridium. That's how the radial strength was maintained, and the strut thickness became thin. And one important thing, limits of the stents. Nowadays, we put stents in the bifurcation. The proximal vessels are bigger, distal vessel is smaller. We take the size of the distal vessel and expand it to the proximal vessel. That's how we do it. But each stent has its limitations. Up to 3 in the Synergy platform. Expedition, it can go a little more. Onyx, it can go up to 3.5. So we need to know about each of this. This is actually, need not mug up. This chart you can put in your labs. So that's how, if you have to go stent so as to have expansion up to 5 plus. Then extra large vessel stents, some of them are launched. Resolute Onyx launched before, and Expedition has Sierra, and Synergy also has size to become bigger, around 5 or so. Then that's how the Resolute Onyx, out of the available ones, are being used more commonly. Then this is at various atmospheres of pressure. Nominal pressure is where the stent, about 2 mm stent becomes 2. That is the nominal pressure. But if you increase up this shows, but again, you should not cross that expansion limits. So 2 should not cross 3.25, 2.25 should not cross 3.25. Basically, below 2.5, you have one tube. So if you have to have a bigger size stents, then probably 3 plus would go up to 4.5. That is a broad way to remember. But depending upon anatomy and patient lesions, we select it. And that's how the stents, even the 2 later on, it also came in the Zymes platform. And various Indian companies also do have that. Such sort of critical lesions when you're doing, and when there's no osteal LCX disease, then probably you tend to do a crossover stenting. I'm not going to details of imaging, which we discussed from the, so you're taking stent from the left main to LAD because LCX is free. You dilate the stent, you see, you size the stent to the distal vessel, then probably the proximal vessel will be bigger. That's where you call it as proximal optimization of the stent. So that's the result, make it opposed in the left main. That's why the proximal optimization with a bigger sized balloon is done. But when you're in the process of doing it, in the earlier version of stents, when you're expanding proximally, they used to become narrow distally. But the change anatomy, again, below, the stent anatomy does not get distorted if you are within that expansion limits, what I mentioned. So that's why it's very important to see, and so that the distal anatomy of the stent here should not get possible with the latest version of stents. I'm not going to detail such sort of good outcomes are possible with the present generation of stents which are available. See this again. This is again 80-year-old outpatients also started simulating West, the ischemic LV of recently, and see this type of tortuous vessels. In the earlier version, earlier generation ciphers, you never could track such lesions. See this, identify it well, and when you're dealing with such tortuosities, placing the wire and everything gets into very focused narrowings. So you need to identify yourself the proximal point and the distal point where you have to place the stent right, so that the branch point, even if the anatomy gets into kink with the concertina effects. So that's how you should try to identify these marks. And always when in doubt, to get back the stent, image with the contrast again, place this lady. So this patient, we had to see this tortuosity of the vessels, so many. Then we initially took one wire, and luckily the wire went in easily. Then we thought we could do it. But as I said, the arteries started becoming more and more kinked. There is a small ectasia there, and then the stent was getting stuck there with one wire. So we dilated it, thought there was a tight lesion there, we dilated it, but still stent was not tracking. Again, getting snip was used again. That I call it stirrup technique. Generally, if two wires are tucked together, it becomes very tough there and becomes straightens all the loops. That's how we could place the stent right. And whenever you cross the lesion, stent should slide down still proximal to the lesion or within the lesion, so you'll end up missing the lesion. Always when you cross the lesion, try to push the stent down and see whether it is tracking down easily or not. Then only that means you have crossed the lesion well. So then you do that, and then you position it well, see the branch, and then that's how once it is done, the proximal one are also easy. And such sort of tortuous anatomy is generally in the calcific lesions where you find it more challenging. Probably we prefer Onyx type of platforms, which are slightly more trackable. See this, the entire artery lesion here was treated, lesion here is without much of a problem. Some of the newer data which are dealing with 80-year-old patients, like high bleeding risk, what we call. So giving dual antiplatelet therapy is a problem now. So people started thinking whether we can decrease the duration of antiplatelet therapy or do away with dual antiplatelet and giving only one antiplatelet drugs that are done in US and Japan, saying that instead of giving 2 drugs, giving 1 drug could be beneficial. It's important for us to realize this patient characteristics of high bleeding risk, age more than 75, and oral anticoagulation, renal failure, planned surgery. Patient is having some TKR patients hospitalized for history of bleeding, thrombocytopenia, cancer being treated nowadays. We also see such patients, strokes, chronic liver disease, NSAID use, or adapt non-compliant. Such are these patients of high bleeding risk. If you're dealing with shorter antiplatelet drug therapy, that is like Resolute Onyx. Then later on, Zymes came with Zymes 1 that saying that 1 month adapt and things like that. So if you see this in Onyx 1 clear, within 1 month, dual antiplatelet, which was continued. Mind you, we are not comfortable putting only an aspirin, though some of them, 40% of them are only aspirin even in this. But nowadays, when we tend to do it, we tend to continue clopidogrel alone, avoiding aspirin. So that's how the patients initially were having an aspirin and clopidogrel here. The outcomes were much better. Doses was not much increased, but bleeding was decreased. And that's how they showed that this stent works well. And clearly met the primary endpoint what we thought after DAP discontinuation also. these high-risk bleeding risk patients of dealing with HBR patients and patients due for TKR, things like that, also with 1 month antiplatelet therapy, followed by single antiplatelet drug later. I will show you some examples of one of the tortuous vessel. I've already shown the small vessel PCIs. Diameter-wise, it could be small, but it could be long, supplying a lot of areas. It's especially seen in diabetic patients, and probably 65% of these small vessels which are not treated. Distally, you leave it, but airport vessels, all these were dealing with the problem. Now, with the availability of better quality stents, and this sort of using this sinusoid technology, core wire technology, and radio opacity is also better. All vessels, when they compared, actually they did well. Thin struts also matters, I think, to decrease the restenosis rates and keep the areas more. And both the extra small vessels also behaved well, and especially even in diabetic subsets in this. So 2 mm clinical study was extended even in US. That's how the recommendations came that you could treat even 2 mm vessels, provided it is important area of supply. So then they did all right, reached the performance goal. Thrombosis rates were not much different, and late lumen loss was also not there. If you see some of the case examples which we faced, a very thin vessels, 68-year-old female. For sake of time, I won't go into details of all the clinical stories of the patient, but show you the pictures. Big lesion here, the tight lesion here. We wired it. Some of the challenges, again, you could take the help of body wire, then take to distally very thin, 2 into 30 stent was taken, then proximally again 2.7 to 30, entire artery is reconstructed. And the beauty of this is distally inside, and it will expand better. You can expand the proximal portions with bigger size balloons also. That is the advantage of the later generation stent. This is another 74-year-old lady, and initially stent was done proximally, then it developed in LAD, now it had developed a new disease in LCX, good outcomes on the follow-up. Then when the left main was also diseased, then probably you tackle that and dilate it, then the patient had final good outcome. That is the things what is shown. This another patient presented with unstable angina. See this, only OM. Normally would leave it if it is thinner without availability of this third, then it is tackled, and then patient had a good result. So this patient's angina decreased and then improved well. So another patient who came after LED stenting before, and distal to it, you have tight stenosis. Many of them, and he was requesting something to be done. So we were not sure whether we can tackle it effectively, because distally again could dissect and lead into trouble. With the availability of this thinner struts, we did do it, but again the proximal to it detects NC balloons and dilate it again within the stent, and finally patient did fine. So already thinner stent struts, if you don't expand it well and residual narrowing, then they tend to restenose more. That's why you need to get the optimal result. This is another thin vessel, looks like very thin vessel but long vessel, critical stenosis. Then multiple stents being put. For the sake of time, not going details, but entire arteries are being reconstructed, and because of less restenosis rates, less TLRs and follow-up, we are able to give good results to this patient. I think anterior MI stent had a total occlusion of LED. We crossed with fielder XT type of wires. Another usage of this thin stent, I'm trying to show it here. The vessels were done. The flows were not established, but later on, we put another thin stent distally, and that's how the entire artery could be revascularized totally. So when we are trying to see, the stent struts became thin, and then probably we had a better polymers. Then people are trying to see eliminate the polymer or holding metals totally. That's where the research was going on. And if you see this Orsiro stent, which has 16 microns thickness, and compared with Zines, and one of the studies showed better. But when we went on to see target vessel failures, again, with all the time, the randomized control trial analysis, then TLFs were not much different, even with regular compared to Zines. Stent thrombosis was also not different. So that's how they said that resolute onyx and Orsiro were also compared, which actually this particular thing was less with resolute onyx, but even with this other one was not much high. So that's how, even making it further thinner, people thought it may not have additional advantage. So then various types of comparisons with bare metal stents, various types of other drugs is going on in this randomized trials, but it is difficult to further improve on this good outcomes, low TLRs already. That's how I think then they've made it further thinner synergy stent, and absorbable polymer, what is there in it. They try to compare with a non-absorbable polymer versus absorbable polymer. It didn't show much of difference there. We had some advantage. That's how the biofreedom stent was tested. The microporous structure was done, and the bioluminescence drug was implanted on that direct metal with micropores. But again, decreased event rates compared to bare metal stents. But when we compared it with other regulating stents, then again, there's not much of difference. This sort-out trial compared the biofreedom with Orsiro. Again, it was not much of a difference. On the other hand, when the bare metal stents showed some slightly more events than the biocompatible polymers, people thought they're protecting from the thrombosis happening. That's how I think more patient-friendly polymers are being preferred. Totally get away from the metal and not have metal at all. The bioabsorbable platforms are what is being tested, because especially young patients and patients who need surgery before, later, and then you don't want it to be having across the branches, bioabsorbable stents. Initially, Igaki Tamae came with a PLA-based thing, BVS, which was done from Abbott. It was already launched, hyped much, but it was used irresponsible, was also bigger. That's where I had some issues. Then further research is going on with river platforms. It's about to be launched, and Biotronic is working with a magnesium-based platform. This is absorbed BVS, fully absorbable, but the strut thickness was 150 micron, like a science platform. Then balloon expandable, 150 microns was the problem. Radial, same multi-link design, was used to PLLA polymer. Initially, it did all right, but when the follow-up results, then it had more thrombosis rates, and stents landed in trouble with 3 and 5. If you see this, immediately after stenting, if the restenosis happens, it is going inside. But if the stent struts get absorbed over a period of time, the luminal area could increase with the bioabsorbable. This endothelium inside could become more resistant, and it's like golden tubes, he called it. If you see this, stent struts, post-stenting immediately, 6 months gradually getting absorbed, and this endothelium became more resistant, and that's how I think the vision was, it works well, and follow-up patients doing all right. But because of improper bed preparations, a very thick supposed to be good with this BVS once the metal goes. But in real world, it didn't happen. That's how it was withdrawn. Then if you other advantages of these absorbable stents, what it's showed is some very well shown in this OCT studies. If the strut is across, like a normal vessel. So that's how the advantages were thought. Then overlapped stents were also being done. That's how I think when you overlap it further, the thickness increases because each of them are having thick struts. We're part of this. And then, because of the more problems on follow-up, then this was withdrawn from the market. Then when people went on to see what was the problem, how to improve this technique, probably bed preparation and definitely imaging, and probably better quality would help. And how to improve the device, probably by making the struts thinner, which was not 150 microns, and improve mechanical properties without much of strut fractures. That is improving the radial strength of the absorbable platforms would be better. And then the Biotronics magnesium platforms are working on it. These are the first generation one, which had a very thick platform. Initially, it started with 228. From where at 150 range, it was launched into market. Then it's further coming down and down. And now this Merrill MIRES is 100. They call it as MIRES 100. That is 100 micron strut thickness. Advances of BVS less than 99 platform. It didn't come to the market yet. But 26th January, as latest as 26th January, MIRES stent is launched in the country. It's available for the patient used. And one important thing which they made is it in the same stent and the same cost, so that you'll be almost mandatory to dilate it pre, and again do a dilatation post with a quarter size balloon bigger. So still we want a better stent to be working in all this routine everywhere, and without having the stent struts. That's where our vision with absorbable platforms. Then when you compare with MIRES 100, absorbable, again, as I said, is 150 microns and MIRES is 100. So that's how strut thickness have decreased. So if the less of the strut thickness, probably people think that less of thrombosis could happen. But at the same time, then a patient that scaffolding is open and closed cell design combinations, then probably patient this stent could have maintained the radial strength. And the markers have also improved. They've made 3 markers on each side of the stent so that you could see the stent better. Previously, when you were not, so closed cell versus open cell, which is bigger, is a combination of this with this MIRES MyWell platform. The study which shown that at 3 years, it is getting absorbed totally. And that's how the radial strength is also reasonable, again, radial strength, even with this. And they're trying to work on this even in the intracranial aneurysm parts, peripheral areas. And that's how Merrill, India, the company is making India proud. And they're trying to work on various below-knee stents platforms also, not the same material. Hope it works well and it will be useful for Indian subgroup of patients. Coming to the most important aspect, and which many people of you also must be waiting for, is how to touched upon the latest bioabsorbable platform also, and then which stent should be preferred. And these are the broad guidelines. Each of you could become comfortable with any of the stents of your choice. But generally, some advantages to mention here. Younger patients, probably age less than 40 years. These are the patients who wear the stent struts. If they disappear, it is good. And these are the patients also maybe less chance of thrombosis could be useful. But if it is not available before, probably we were using longest follow-up study platforms like Zymes and Resolute before these younger patients. But ideal BVS could be a solution in these patients. Coming with Onyx and Zymes, short DAPT studies, and we need to club this with the proper radial axis to decrease the bleeding. So probably in elderly, you should keep the stents in which have a least thrombosis, and then short, particularly addressing with design stent, but even other stents had about 1/4 of the other studies also had some females, but we are somehow more comfortable because large data is generated in females in this. Diabetics, initially Resolute platform got approved by US FDA. Diabetes mellitus trial, the Indian abdominal stent is again being tested with Zymes platform. Probably this could be an effective Indian solution for in diabetic patients too. Recurrent MACE events in patients which is likely to have probably instant like Cypher of Esterera of Zymes. And the patient has CKD, LV dysfunction, try to keep the technique simple and don't put too long stents and try to limit the size of the stent and try to do a quick job and come out without. Another important thing, I think coronary anatomy factor is very important. When you're dealing with the left main or LAD, LCX, RCA, osteal locations, we have to place the stent very precisely. The Zymes platform where the stent is what is preferred. A left main crossover requiring a part again, the proximal should be big and distally should be thin. Then probably Onyx design is preferable because it doesn't distort the anatomy. The Sierra also has a higher size preferred there. Bifurcation of the large side branch, we need to have open cell design stent. Previously, we were banking on Onyx, and now Sierra also has a larger side holes, and then Synergy also has some similar ones. So in open cell design stent. Tortuous vessels, you need to have the lowest crossing profile. Probably some of we tend to select Onyx platform, which are shown in that 80-year-old lady with a large tortuous LED. Small vessels, that is less than 2.25, we are very tend to use that. Calcific vessels, where you need a higher radial strength, probably Science platform with a longer follow-up with a good radial strength we prefer. And especially when you are dealing with a patient in which instant restenosis have happened, probably you prefer the restenosis, you decide. But if the stent expansion, under expansion is a problem, you expand it well with the regulating balloon, you treat it. But if in spite of all that, if it's diffuse atherosclerosis, probably you can use alternate event in paclitaxel versus limus. But now at least one drug type of stent restenosis, we tend to select the other. So these are some of the broader guidelines, I would say. But each of you should become comfortable with one or two types of stents. Which coming to it, we have come a long way from the evolution of PCI. It is exciting rides with many twists and turns. But I feel the best is yet to come. If you see this was proposed by Antonio Colombo, a great man again. Rather than making it vision, without that, immediately if it leads to occlusive dissection, probably you could use one focal stent or a BVS. If it is optimal result without a major dissection, then probably you can assess the gradient and do a spot disease. Whereas if gradient is more, when you definitely need a stent, probably you can do BVS or a short metallic stent. So probably rather than making the entire arteries through tubes, some of these distal diffuse disease could be tackled by drug-eluting balloons also, but we need to have more data with them. Putting too long stents, many of the youngsters where we see, especially in primary scenarios, in emergency situations is different. But otherwise, you prepare the bed with a tight focal lesion, you inflate it, give nitro, and then assess the vessel well distally and take the whole extent of the stent, you cover it, or artery, you cover it the stent. Basically, wherever you find a minimal disease, you can still do rather than putting very long stent. I think that's what we need to use our discretion experience to give optimal results to patients. I think with this, I'll go for taking chat questions. So the quiz is also going on. Probably you can express your chat questions, send questions in the chat. I think many of them answered the Kahoot quiz things also in this chat questions. One question from Ramya, sir, any choice for thrombotic type of STEMI type of lesions I didn't cover basically. We were worried to use drug-coated before, now I think they're proven beneficial and there is no problem to use any type of drug-eluting stent also there. Previously, mesh-coated type of stents like MGUARD was being tried. Now it is given up because it was a polymer type of stents which have like Exine's platform, which is supposed to be having albumin selectively attaching there without antiplatelets clogging there, probably could be preferred. But long stents in that scenario, and try to use a stent length which is optimal and as required to tackle this thrombotic patients. I think now with this, I'll try to go on to the this is finished. Give me 1 minute, please. Now we'll go on to this advanced stent quiz. Not opening. What is the problem? Are you able to see the screen now? So we need to have the pin. those chat questions. The pin generation is not happening. I think now it will work. This is the pin 0432826. Please log in with this pin 0432826. So not many people could log in. Will you wait? What is shown here, they said for the winners, they would give this thyroid collar. A new pin has come. I think with this, this is live. I started practicing it before. That's how the old pin is coming. This is, I think, you have to log in by this pin. Please try once, otherwise we'll give up this. We'll take some chat questions before we break. It's already 7:30. 033-55-528. Some of the important aspects of what we discussed also could be covered. Stressing points. That's how I thought we would have with this. Major advancements in stent type, coating, all of it has happened. So all of the above is the answer. Probably many of you are not able to participate. You can write in the chat if you want. Which is the main stent design which matters in bifurcation lesion stenting? Bifurcation lesion drug type matters most. The top diagram here actually shows whichever the open cells which have maximum diameters available. I think open version, which will deal more in this thing. And then we finish the two questions. This we did it already. Today it is creating a little more trouble. The other, the most important character of stent for the left main stenting. Which type of a character is very important? I said when you're doing a crossover stent with the expansion limits have kept on with proper studies and what is available with the imaging, you take the prefer that stent there for the left main stenting. Then if you go to a stent with the maximum number of studies and randomized data as of available today, earlier were Cypher, now I think Science has the maximum number. This is the most latest generation stent on the platform which has come. We need more studies with it. And resurgence of bioabsorbable stents is brought by which stent company? Probably you need to type the answer here. That is Midas 100 of Medicine. Do this right this time, but probably we'll again further evolve for what is this problem happening. So that's how I think you have finished this. But I'll close down this, stop sharing, and we'll keep everybody on the screen, and then probably have some chat questions if you have anything before we break. Did you go back to this the previous screen?
Sir, it is showing us Kahoot Advanced.
Yeah. Okay, so we go on to the chat questions. I think the last slide which I wanted to show is also important. Conceptually, people should think about this also. Decreasing the amount of metal in the stents, how to proceed it further, whether take help of regulating balloon, and how to optimize results. Then the new concept which is coming up. Probably we can limit the amount of metal in each. Those stents are performing well. Nothing replaced to all patients' own vessels. I think with this we should close on this, and I would be happy to take any chat questions. Thank you. We can make a gallery view so that as many as people can see.
Sir,
is it possible? Yeah, I think now I'm able to see the chat questions if something has come. Dr. Ravindra Reddy has asked me before that what is the Sorry about this confusion about PIN and other things. Many of questions are on that. But I'll take questions one by one. Dr. Ravindra, what is the stat? I mentioned the talk. The more thinner studs of the available BBS supposed to be good, and 100 microns thickness of mirrors, that's why we call it as 100, is launched in the Merrill. And other companies are also working on it. The BBS next maybe same like 100 microns. Then people are also working with the metallic platforms with magnesium absorbable metal, that is from Biotronics happening. And the Riva Medical Systems is happening with the BVS, where their advantage of that is supposed to be radio opaque. The end for radio opacity, the rest of the stent is not radio opaque. The Riva platform wants to work and make the stents a little more radio opaque also with the BVS type of platform. Those are the things which are going on. I think we need to use this stents, newly available BVS with Meris carefully and prepare the bed. Then Dr. Deepak Patade, change in the DAP strategy, new stent technology. So that's what we are thinking, that we should avoid giving long-term DAP therapy, especially in high bleeding risk patients. But in younger patients, it doesn't matter really in India, but probably in elderly patients where you have a high antiplatelet therapy duration, maybe limited to first 1 month to 6 weeks, and then gradually go on to single drug. And somehow we are not comfortable stopping the more potent of the antiplatelets. We tend to stop the aspirin if it is required and try to continue only clopidogrel in this high risk only now. But in HBR patients, probably you could still use clopidogrel. And Dr. Nilesh, what will be your advice for beginners? Which stents to use? I feel for the beginners, actually, what is the best available and what is tested, and if you use it, then probably even if some issues are there, you'll be also protected, because the national stents with USFDA approved platforms, if you use, probably in these times of litigations and problems, 50% of headache will go away from you. And again, probably use the best possible FDA approved stents. Like what, don't keep on using a 1-1 stent of various types. You become comfortable with 1 or 2 types, which are 2 to 3 basically, to have the different sizes available, overlapping. Sometimes exact sizing may not be available in each company. So probably 1 or 2 of those. And then you should also become comfortable with the inflation patterns, the nominal atmospheres. Because Science platform is a nominal of 10 atmospheres, where others will have a nominal of 12 and 14. So those are the things, intricacies, sometimes you should be careful. And that's how I think in our group, we tend to work with the multi-history patients at lesser price. And even the youngsters who are doing also should not have this headache of some of these balloons. Indian companies tend strut thickness is quite good, but sometimes we tend to get deproximation and then clipping off the stent platforms on the balloon. Sometimes occasionally could be challenged. So that's how we tend to switch on to the most maximum available data stents in all subgroups of patients. Dr. Ramya is asking, good evening, sir. Any choice of stent design? If the what I said in calcified type of lesions, and if you have you need a better trackability on one way. At the same time, radial strength also should be good. So you need to have a strut thickness again being less, and also radial strength also should be good. So that's how we tend to use Resolutronics or the Science platforms. Hi, sir. What is the status of abdominal surface coated sirolimus stent with biodegradable polymer matrix? What is the true importance and data? That's what is abdominal stent. Abdominal coating of the drug is only being tested. The other advantage of that platform is now the stents have the drug only on the stent struts. They have a drug-eluting balloon also of their own make. So even the balloon on which the stent is crimped, they're having a drug. So that the entire surface of the artery, the drug is at least deposited once. So it is not a stent over it. That's how it is. And the uniform distribution of a drug, what they claim is supposed to be maybe better. And the stent ability diabetes mellitus trial, which I mentioned, they're trying to compare to the Science platform. Hopefully, we need to wait for the results. And 1,500 patients ran. Antonio Colombo and Marie-Claude Morris are the PS for it. And they also requested many of the Indian operators to be part of it. Dr. CV and Murthy, are thinner struts better, or is there an optimal thickness? Yeah, that's what we discussed. Right from 150, now it is around somewhere, the least one is of 60 microns. And somewhere around 80 could be okay, because if you make it too thin, again, the radial strength could decrease, and sometimes you could land in stents becoming crimped and shortened. So that's how people are working around mostly. Go down further below, you may not achieve further better results, but on the other hand, you could have a less of radial strength, and then probably stent shortening, things like that would happen. I think these are the pins which are entered. I think this time you couldn't enjoy the Kahoot app very much. Then they would help you with that thyroid collar. Many of them would get anyway. Then Andrea Gunzig is what is the type of thrombotic lesion stent choice I've answered. Covered stents, this is a good question. Valim Pasha. Then what is the status of covered stent? Because these covered stents, however thin the cover is, like papyrus coating which has come now, which is a 5 French compatible, still used only in patients of where you get perforations with regular stent, because again, the covered stent, the more covered it is, the more chance of restenosis is required. All other questions are regarding the pin. I'm sorry for it. Is this different pin or from the liver? Regarding what is the current role of drug-eluting balloon? Current role of drug-eluting balloon is basically people are trying the various concepts which I showed in the end also could increase the use of drug-eluting balloon. But as of now, that is especially when the expansion of the stent is all right, but only atherosclerosis has happened. And within the, if you see that less than 50% of the material gets deposited in the strut within the stent. Second thing is probably in a smaller vessels where the about 2.25 or 1.5 vessels, then probably where you can't afford to put stents, long diffuse nature of disease, again, probably drug-eluting balloons could be used. And people malignancy elsewhere in the body. So that's how paclitaxel is becoming less common. The now Limus-based drug-eluting balloon, Magic Touch balloon, the Indian company made a world proud, and again, that is being tested and tried in more number of patients. That is the answer for drug-eluting balloon. For osteal lesions, which stent to be used, that's what I mentioned, for to advantage, to position it exactly at the ostium without coming onto the main vessel. And again, you have a good radial strength too. That's how we prefer using osteal lesion that stent. Dedicated bifurcation stents patient presently, tapered stents also, proximally bigger and distally smaller. The tube is same, but the balloon has differential expansion capabilities. Actually, Merrill made one, and other companies are also trying for it. But basically, even the other ones, regular ones, which have more complex nature, proximal expansion can be made bigger. Merrill made one, a tapered stent, and one or two other companies are also trying. Dedicated bifurcation stents, basically, we need to preserve the access for branch always, and then various types of specialized bifurcation stents are seated. It became 7:30. I did deal with it in detail. I would take up all that in a bifurcation session, coming up things. I think with this, I think a lot of questions are done. I think it's already 7:45. If there are no further questions, I think we'll close this session. Is it okay?
So Vignesh sir had some connectivity issues, sir. So
okay,
yes.
Okay. So I think we'll, it's 7:45. Thank you again for all of your interest, and thanks for participating. And the next approach, I'll tell you the concepts of multivessel PCI, how to decide, and show you some interesting case examples too, and also touch upon utility of FFR and QFR and how to deal with it. And probably we can have that on 27th February. That is the last. We would remind you again. Thank you once again for all your patient hearing and active participation. This I close.
Yes, sir. Yes, sir. Thank you, doctor. Thank you for the wonderful session, and thank each and every doctor for participating in this Cardio Next. The next Cardio Next session will be. Thank you, sir. Thank you.